Thank you for organizing this, Bob, of course, and Shaik, and inviting me here to give a presentation. These are exciting times for Hamad, and I start with the same picture. I didn't know that, of course. I saw it yesterday. But this is for my department. So we go back later on. We go back to the ground floor where I work, and I see, and many of the things we heard yesterday, I try to implement, and we can discuss that. And but these exciting times are these big buildings. This is the biggest commissioning project in the world at the moment. And these big buildings, for me, this will extend my department, and that's anesthesiology, over 8 hospitals. This will extend my department from 30 to 32 operating rooms to 64 operating rooms. We will go to almost 100 PACU beds. So we have now 30 PACU beds. And in next year, when we open all this, we have 100 PACU beds. And I have also a SICU, the Surgical Intensive Care Unit, with around next year 50 beds. So this will be a huge undertaking, going to double my department. At the same time, I will tell you a little bit of going to an academic health system and to an academic department. This is the entrance to the women's hospital. So it's beautiful buildings, and it's one of the things why you want to come to Qatar, because when you are an anesthesiologist, you can work in the most modern operating rooms. But this, to go back, to see my context and what I did in my country before, this is in Holland. This is my department. On the right side of the slide, you see my department having a Christmas breakfast in the hall of the hospital. And on the left side, you see the acute and chronic pain group. And you see a different picture later of the residency program in my department. And you can see the differences. What I did in Holland was, I was an anesthesiologist, but I was also the chairman of all program directors in anesthesia, and I was the chairman of all program directors in the southeast of Holland. So, and Holland is divided in an education region of 7, so around 180 million euros I could spend, I was responsible for. And this is a totally different country to project, and that's to Dr. Sousa yesterday. He said you can't predict anything in life. We try to predict how many people we need, how many specialists we need. We see Holland, and I think they still do. I'm 3 years I'm not there anymore, but we see Holland as a sort of separate community in Europe. And we try to predict how many specialists we should have. And also the minimal competences, we tried to set the minimal competences for the Dutch specialist, and we try to strict everything. So the budget you saw 1 billion euros, is on a cure budget of around 30 million euros. It came out of the cure budget. They just separated it from the cure budget, and that's the way we could train specialists in Holland. We did it for anesthesiology, so I was sitting in as an expert. Because everything in Holland is so arranged, we try to predict this so that we didn't teach too many, that we didn't train too many specialists, because that's very expensive, of course. So what you see here is a prediction model. From 1972 till or around 1995, Holland, the Dutch government tried to predict how many specialists we needed, and they were not very good in it. So they gave this back to the insurers, to the experts in the field, that were the specialists, and to the medical schools. And we had to predict, with the 3 of us, the three societies, we had to predict how many specialists we needed. Insurers want to have too many specialists because that will decrease a little bit the price, what we offer. The specialists want to be maybe a little bit under because that raises the price. And the medical schools, they want to stabilize the training. So they are even. On the left side, you see the year T. And in the year T, that's your supply. You start your prediction. That was in 2000, the first time. And you see in the upper side of the slide, on the left side, you see, on this side, but I have to do it on two sides, of course. And you see the supply and the demand on the time of the prediction. And you see the gap in between. On the right side, year T plus X was 2000. 10 years later, we tried to do it 10 years or 20 years later. You see what you want to have. So you have to predict what you want to have. You have to also to predict how many of an FTE, for example, a full-time equivalent, how many percent you want, so the women want to work, that you have to predict. All these predictions comes into this model. The Dutch Bureau of Statistics is doing then the middle part, where they did all this, they've sent out questionnaires for your prediction. And here, what you see here on the middle is then your influx in your medical schools, when you also have predicted how many people come from abroad. This was not working, of course, so you can't predict the future. We heard it already. And we then get all kinds of scenarios in it. So also we talked a bit about this vertical and horizontal substitution, which is big in Holland. Vertical substitution is that doctors don't do all the tasks anymore. For general practitioners are not seeing the diabetes patients anymore, but nurse specialists. Horizontal substitution is that you, for example, an anesthesiologist is not doing all the sedation in the hospital. We can't do it all. So we train other specialists. And all these scenarios came in. And then we became quite good in prediction, a prediction model, how many specialists we needed. So here you see, in the beginning, in 2000, when we didn't put in the scenarios, you see that we've asked for many specialists, and we only got half of it. But in 2006, we are almost in the middle. And when you see the outcome in 2010, we were quite good. Did it work? Did it really work? Because I worked also on the ground in Maastricht. So Maastricht is not in the middle of the country. Everybody wants to live in Amsterdam. Amsterdam is a place to be. In Qatar, that's Doha. In Holland, you want to live around Amsterdam. So I was living in Maastricht. And what you see is that you don't have enough specialists in Maastricht. So when you are not in the middle of your country or the middle of the earth, New York will have more good specialists than Maastricht. That's more the middle of the earth, maybe. So here you see that when you live in Maastricht, you still need some Belgian doctors, some German doctors, but they are well trained. We also set all the training, the minimal competencies for that $1 billion we could spend. So we set all the minimal competencies, we trained them, but we trained them all where. So we set with all the program directors, we set once a month in Utrecht, that's in the middle of the country again. And then we try to get the whole training the same, and we also get not only the training the same, but we also had central exams. So we had a very average workforce, good workforce. Where you do this for is, of course, for quality. This is the end outcome is always quality. You want to be better in quality than anyone else. So you want a good workforce for your outcome data. This is the mortality after surgery in Europe, which you can have many of these studies. And this is a study that shows that Netherlands is somewhere up there and has a low mortality. I don't think it's low, but it's a whole other question. Low mortality after surgery. When you live somewhere else in Europe, you can have a 4 times as big mortality after the surgery. So this is some quality outcome, and that's why we are in the Netherlands high up in the standards of the United Nations. So now I moved to Qatar, and that's I came into a different situation. We didn't have these prediction models. We didn't have this average workforce, this average quality. So in my department, I had to do something, of course. You heard already that Qatar relies heavily on an expatriate healthcare workforce. And they have different levels of training. So that's what I saw also in my department. You come into your department and you think, you have very good ones, but maybe some other needs to be trained. And where do you now start? This is all also in the middle. This is all coming out. This is literally coming out of the Qatar National Health Strategy from 2011 to 2016, and we live that the global health workforce is not enough, and they are moving around to the best places. So we needed to do something in the department, especially also because we wanted to go to an academic health system. I don't come from an academic health system to something less. I want a better workforce in Qatar. And so you have to start somewhere in your department. You already heard from the different levels of service, specialists, so we have residents, fellows, specialists, consultants, and senior consultants. You also want to connect to your medical schools. We want some students from our medical schools, from Cornell. We want to be a good place where students want to go. Also from Qatar University, just started, we want to get some of those students. So you have to do something in the department. So these are all global things. I will skip over this. This is, for instance, what we did, and we started with, under the vision of Dr. Abdellatif Al-Khal and Dr. Hanan Al-Kouari, we started with a residency program, which is very important for a department. Here you see my residents with some of the trainers, and you see already a totally different kind of workforce than you saw earlier. This is also the nice thing, of course, of working in Qatar. I work in my department with 67 different nationalities, and I learn a lot from them. They are very kind, and they always come with presents, and I've never seen something like that. So the ACGMEI accredited residency. They already started it in other departments, so that was easy. We had foundational requirements. We had them already, otherwise it wouldn't have gone so fast. We had some residents in the department, but it was not a competency-based residency program. So we started this ACGMEI accreditation of our residence program, and in 4 months we made it a competency-based residency program. I had some experience with that in Holland, so we could do it very quickly. But it will also change your department, your faculty. For your core faculty committee, your clinical competency committee, your program evaluation committee, you need many people. And your faculty, so you need 30 or 40 of your faculty. They have a totally changed mindset when you do this. We do the evaluation, of course, now, and we also try to get them seamlessly in a fellowship program that's 3 years. So it's a long time, and they do sort of 2 specialties in that 3-year fellowship. They do, for instance, obstetrics and pediatrics, pediatric anesthesia. What did we get out of it? We get some that are already had the IRIS boards. We have a 100% success rate in the error board. We have a continued faculty development, of course. We do all kinds of courses, day-long courses with the faculty. And we are ready, hopefully, for continued accreditation on the 4th of May. But I think we are quite ready for it. Another program we do at the moment in our department is the specialist. We want to move out of the specialist grade. I don't look at people in my department as different grades. And I said that in the beginning already. I don't see them as senior consultants, or as specialists. I see them as competent or non-competent. And that's far better. So we should pay them, of course, in the end, as competent and non-competent. So we moved already a lot out of the specialists. There were very good specialists, but they were not promoted because maybe of sometimes of cultural background. That's not there anymore. We can promote everyone. The competent are promoted. So we already moved from 115 specialists in my department to at the moment 67 specialists. But how lower you go, how more difficult it is. Most of these people can't go back to their home countries. So we have to be very lenient with them, but also I want them to increase their competencies. So what we did is it's this anesthesia specialist program. It works like a sort of mini residency program. We 5 to 10 at a time will be trained and will be going over all the departments in my department. So they will do intensive care again, they will do pediatric anesthesia again, under supervision. They will be 360 degrees evaluated, they will do DOPS and everything, and we will get out of them, and they will be promoted then to maybe a junior consultant. So everybody has a chance in the department to be promoted and to be in the right position where they want to be. And that's all to connect to your medical schools, to get a workforce, and also to be, so I don't advertise, and I get something like 2 CVs a day, people that want to come in our hospital. So it's this is seen in the world, it's spoken around, and people just want to come to Qatar. So this is a little bit what we are doing on the ground. When you have questions later, certainly try to answer them. And what we also see in Qatar is a nice environment. When we do a lot of work, we are also recognized. Here you see a picture of the Excellent Medical Education Awards, and Dr. Abdul Latif Al-Ghal is standing there and giving a prize to this. This is the competency committee in my department, and he gives a prize. I can hold it, but it's like the World Cup. Everybody can hold it after that, of course. And Professor Mike Richmond is standing in between, smiling that we are doing a nice job. Thank you very much.